Dr. Samiha, junior assistant from TDMC, Alapura. And the mentor is the professor and HOD Pediatrics, Dr. Srilata Madam. Welcome, Srilata Madam and Samiha. Next, I would like to welcome our Secretary IAP Kerala, Dr. Gopi Mohan sir, Treasurer Dr. Ranjit, who is behind the Zoom, who is holding in charge of the Zoom, and the PG Cup Coordinator for IAP KOTTAYAM, Dr. Thomas, to the session. And I would next, finally, I would like to welcome all the postgraduates who are assembled here for the online session, and also the faculty. I see my teachers, Dr. Purushothaman sir and Sushma madam, all have joined here. And the Yashwan sir has joined, Jayaguma sir. So I welcome each one of you, and also the other seniors and colleagues. So welcome all. Thank you. So have a happy learning.
Next, I request Riya sir, President IAP Kerala, to say a few words. Riya sir.
Okay. So, respected President of IAP KOTTAYAM, Dr. Nisha, my most respected teachers here, Purushothaman sir, Mohandas sir, and Devarshan sir, Darli madam, Srilata madam. Then I could also see Devuma sir, Sushma madam, and many more. And dear students, so this is now our program has gained momentum, and we are routinely having programs every week. Every Thursday, 7:30 is reserved for postgraduate teaching and learning. And in the new year, we have brought in more varieties. Like we had an OSCE, we had a what you call a thematic lecture, interactive lecture. Then we will be dealing with various topics again. And I congratulate KOTTAYAM team for doing this at a short notice in a very nice manner. I wish best wishes to the faculty today, and also I welcome her, Dr. Smilu. And I also thanks Srilata madam for providing the case, the student, as well as mentoring her. So over to the team for continuing. Thank you.
So Mohandas sir.
Sound ഇല്ലാത്തോണ്ടൊന്നും പറയുന്നില്ല.
Sir, കുഴപ്പമില്ല. Next, I invite Gopi Mohan sir, Secretary IAP Kerala, to say a few words.
Thank you, Thomas. Respected President Riaz sir, Riaz, my senior professors Mohandas sir, Anandakeshan sir, Darli madam, Sushma madam, and all the other dignitaries, my dear friends and students. It's as Riaz said, this time we have changed the format, and it has really increased the audienceship of this program. I congratulate KOTTAYAM team, and I wish the very best for this program. Thank you.
And the Yashwan sir.
Good evening. I think we're already late, and already we can start the program. I am happy to see that new changes in the program, different types of classes and talk, and mixture of all the presentation. So I would like to congratulate Dr. Riaz and Gobi, and also I would like to thank Dr. Mohandas Nair and all others for conducting the program in a nice way. And also very happy to see Sushma madam, Purushothaman sir, Darli madam, and all other seniors. Wish the program all the best. Thank you.
Joe sir. Sir, the next, I request Srilata madam to introduce the speaker and the case.
Good evening, everybody. Today I'm interested with two jobs. One is mentoring the presenter, and also I am interested to introduce the speaker, Dr. Smilu Mohanalal. That is the first thing I would like to do. So Dr. Smilu Mohanalal, she's a renowned consultant pediatric neurologist of Aster MIMS, Calicut. She's also the consultant at Aster MIMS, Kottakkal and Kannur. And After her MD and DNB, she has done a fellowship in neurology, pediatric neurology, and also did a diploma in pediatric sleep medicine. And her areas of interest are pediatric epilepsy and neuromuscular disease. And she has presented a lot of papers. She has a lot of publications on her credit. Welcome Dr. Smilu Mohanalal to this session. And today we are discussing a case of Leo, a 6-year-old boy who was admitted to a ward with an acute viral disease. It was a very mild illness. But when he saw the patient, he had some peculiar facies, and he was with that, we went into the detailed history, and we found that he is having isolated motor delay, and we thought we'll admit him for a detailed workup, and that led to this detailed discussion for today's PG Club. So over to Dr. Smilu and Samiha.
May I request Srilata Madam also to chip in and ask questions and discuss, because it will be nice if two teachers are discussing simultaneously. Thank you, ma'am.
Okay, thank you.
We can directly proceed with the case, ma'am. And thanks for the lovely introduction. Thank you, ma'am. Dr. Samiha, you can start presenting. Start with your case, and I'll pitch in between.
Very happy to say that Samiha is my MBBS student here.
Good evening, all. Shall I start?
Yeah, please, you can start.
Today, I'm presenting case of a 6-year-old boy. Informant, his mother, her history is reliable and complete. He presented with complaints of vomiting for 3 days, loose stools for 3 days, and fever on day 2 of illness for 1 day. Child is a non-case of developmental delay, presented to us with complaints of vomiting, which was non-bilious and non-projectile vomiting for 3 days. And he had 3 episodes of vomiting per day, and vomitus contained food particles, and it was not blood stained. It was associated with loose stools, 3 episodes per day for 3 days, which was high volume watery stools, which was foul smelling, and stool was not contained blood or mucus. It was not associated with abdominal pain or abdominal distension. No history of increased thirst or decreased intake of fluid, lethargy, or decreased urine output suggestive of dehydration. There was history of fever on day 2 of illness, which was low-grade fever and subsided in 1 day. It was not associated with headache, altered sensorium, or seizure. No history of yellowish discoloration of eyes, urine, or anorexia. There was history of intake of food from outside, no history of contact with a person of similar illness, no history of recent intake of antibiotics. Child was admitted to a hospital and was treated symptomatically. Since the child is a case of non-developmental delay, I would like to start my history from antenatal history. It's the first child of a non-consanguineous marriage to a mother of 21 years and father 26 years. It was spontaneous conception. The mother had no previous history of abortions or comorbidities. She didn't receive any preconceptional folic acid. During first trimester, it was relatively uneventful and scans were normal. In second trimester, she had felt quickening at 5th months of gestation, and anomaly scans were normal. No history of gestational diabetes mellitus, gestational hypertension, or hypothyroids. Third trimester, she was perceiving fetal movements well. There was no increase or decrease in fetal movements. And USG was normal. There was no polyhydramnios or abnormal presentation. There was history of vaginal discharge at 7th month of gestation, and which was treated with vaginal tablet. No, there was no history of maternal fever, premature rupture of membrane, or foul-smelling discharge. Natal history. It was a term baby delivered out of cesarean section in view of failed induction, delivered a male baby of 3.3 kg and was adequate for gestational age.
Baby cried soon after birth, and there was no respiratory distress soon after birth. Breastfeeding was initiated soon after birth and baby was shifted to the mother's side. And there was feeding difficulty from day 1, and which was initially attributed to inverted nipples. And on postnatal day 2, baby had fever and respiratory distress, for which he was referred to our hospital. He didn't require any ventilatory support, and baby had seizures on postnatal day 3. There was 2 episodes of seizure, and the baby was in NICU. There is no history of hypoglycemia or neonatal jaundice. He was evaluated for same, and lumbar puncture, neuroimaging, and EEG was said to be normal. He was treated with anti-seizure medications and IV antibiotics, and was shifted to mother's side by postnatal day 8 and was discharged on postnatal day 11. He was discharged on palliative feeds due to poor sucking efforts. Anti-seizure medications was continued. Mother has noticed floppiness of the baby, and feeding difficulty improved, and baby was able to feed well at breast by 2 weeks of delivery. No history of reduced activity, paucity of movement, feeding difficulty in form of aspiration, regurgitation, weak cry, facial dysmorphism, or abnormal posture. No history of further episode of seizure or abnormal movement. Anti-seizure medications were stopped at 6 months of age.
Can I just interrupt in between? So what was the reason for the neonatal event? Like, for example, was it considered to be an acute symptomatic seizure, or was it thought to be of some underlying brain abnormality that is causing a seizure?
From history, there is a definite history of feeding difficulty and history of fever. So it might be a feeding dehydration fever and any metabolic abnormalities causing seizure, or a sepsis which can cause seizure. Suggestive of an acute symptomatic seizure, since anti-seizure medications was stopped at 6 months, and evaluation.
And why was it continued up to 6 months? So usually what we see is whenever a neonatal seizures are there, so if it's an acute symptomatic one, we usually taper off and stop by discharge. And I agree that this baby had feeding difficulty. So for 2 more weeks, maybe there would have been a thought of encephalopathy or some component, and that's why the anti-seizure medications would have got continued. But was it continued till 6 months because of any follow-up issues with the child, or any other concerns were there? Was that the reason for continuing till 6 months? Is there any specific reason like that?
Feeding difficulty was actually improved over 2 weeks, and except for this floppiness, baby was active.
Okay, yeah. Samiha, we can hear you. Yeah.
Baby had social smile by 2 months, and baby started recognizing mother by 3 months. And mother noticed delay in gross motor development in the form of at around 6 months, as the child was not attaining neck control, and baby was not able to roll over. And baby was evaluated for the same and was advised physiotherapy, after which baby was gradually attaining milestone. They have discontinued physiotherapy at 1.5 years of age, since he was not cooperating. Now child walks, runs, and climbs upstairs and downstairs with support. Mother have noticed abnormal gait and difficulty in standing up from squatting and lying position, where he uses his arms for assistance. There is no history of swaying while walking. No history of difficulty in wearing or holding chappal, tripping over objects suggestive of distal muscle weakness. There is history of difficulty in removing clothes, pulling and pushing heavy objects. No difficulty in climbing hair or raising hand overhead. He does not button or unbutton the clothes. No difficulty in writing, holding cup, or frequent fall of objects from hand. No difficulty in releasing objects. Mother is complaining that child looks thin with poor muscle bulk. No hypertrophy of muscles. No history of diurnal variation for this weakness or fatigability on exertion. no history of muscle pain, and no exacerbation of weakness on fasting. There is no muscle twitching was noticed by mother. No history of constipation, cold intolerance, or excessive sleepiness. History of abnormal posture of right limb noticed for past 1 year. No difficulty in breathing or swallowing. No history of aspiration of feed. No recurrent respiratory infections. No history of dyspnea on exertion, chest pain, or palpitation. There was no delay in development of other domains. Vision and hearing is normal as per mother's history. No history suggestive cortical involvement like seizures beyond newborn period, abnormal movements, or abnormal sensorium. No history suggestive cranial nerve involvement in the form of squint, diplopia, difficulty in closing eyes, difficulty in chewing, jaw movements, no history of facial asymmetry, drooling of saliva, aspiration of feet, no history of difficulty in straw sucking or blowing balloons. There is no history of sensory involvement in the baby's child is able to appreciate cold and warm, pain, touch, no history of numbness or paresthesia. No history of swaying or difficulty in drinking water from cup, the former, no history of tremors. There is no incontinence or constipation. Past history, no history of previous hospital admissions, no history of seizure other than newborn period, no history of recurrent respiratory infections. Developmental history, gross motor, there was initial delay in gross motor development. Neck holding was attained by 8 months and rollover also by 8 months. Baby was able to sit without support by 1 year, and baby didn't creep or crawl. Instead, he was bottom shuffling by 1 year, stand with support by 1 year, 8 months, and started walking by 2 years. Started running by 2.5 years, climbs upstairs and downstairs, 2 feet per step, holding rails by 2.5 years. Now also the child does the same. No, not able to hop, skip, or jump. Fine motor skills, mother is not exactly recalling the fine motor skills, but she recollects that mature pencil grasp was present by 1 year and started scribbling by 1.5 years. Now child can copy his diamond. His fine motor development is normal, and social and adaptive skills also attained normally. And now his general understanding is good, is appropriate for age, knows number of fingers, names weekdays, knows right from left. And language also he attained normally. Now he is studying in first standard with average scholastic performance, no learning disability, no behavioral abnormality. He interacts well with teacher and friends. Dietary history, exclusively breastfed till 6 months, continued till 3 years. Complementary feed started by 6 months with ragi. Now child is on family pot diet, balanced diet. He eats alone, no dysphagia, no difficulty in chewing or swallowing. He gets 1,500 kilocalorie and 34 grams of protein against ICMR recommendation of 1690 kilocalorie and 20 gram protein. Diet is deficient in 160 kilocalorie and is excess in 14 gram protein. He is not on any supplementation. Immunization history is immunized for age. BCG scar present, no AFI. He haven't received any optional vaccines. Last vaccine at 5 years. Family history. There is history of intellectual disability in maternal uncle, but there is no gross motor involvement. No history of developmental delay, weakness, or sudden cardiac death in family. No history of hypothyroidism. History of abortion in mother, which was a first trimester abortion at first trimester, which was 1.5 years back. Now, while admitting to our hospital, she was 20 weeks pregnant. And since this baby was having some developmental delay, was advised detailed anomaly scan, which has shown some cardiac anomaly and discrepancy in femoral length, and she has underwent MT. Socioeconomic history, father has studied till 10th standard as a driver, mother is graduated as a homemaker. He belongs to lower middle class family according to modified Kipusamy scale. He is not holding any disability card and they have advised regarding same. is going to school by auto rickshaw without any assistance. Summary. This is a 6-year-old boy now presented with acute diarrheal disease with no features of dehydration. Is having an isolated gross motor delay, and his onset of illness is from birth in the form of floppiness and feeding difficulties. And history is suggestive of a proximal weakness than that of a distal, and both lower limb and upper limb is involved. There is no diurnal variation, no episodic worsening or aggravating factors, and history is suggestive of a non-progressive disease, and there is no family history, and history of contracture is present, and there is no systemic features of systemic involvement.
Okay, so with this summary, there was a question also in the chat box. You had mentioned about the abnormal posture of the right upper limb. So can you just describe about that posture, like whether it is a fixed one, whether it's a fluctuating one? So if it is a fluctuating one, what would you think of? If it is a fixed one, what would you think of?
A contracture of the right limb was that his hip was flexed and knee flexed posture, and angle at a plantar flexed, and his right limb is a bit longer than left one.
No, not that. You had mentioned about a right upper limb being in a fixed position. Like you had told, you had briefly mentioned, probably what you were trying to indicate was more of a contracture, which is a fixed position of that particular limb. So if suppose this child had a fluctuating part, like for example, if the child had this kind of a posturing, which is like, and this keeps varying. So the twisting kind of posturing. So what would you attribute if the child was having a twisting kind of posturing? A twisting would indicate more of whether it will be an upper motor neuron you would think of, or will you be thinking of a lower motor neuron? See, by the end of the history, what you're thinking about is whether you're dealing with the central nervous system or not. Yes, you are dealing somewhere with the CNS system. In CNS, whether you are dealing with an upper motor neuron or whether it is a lower motor neuron. So if it was twisting posturing, it is more of upper motor neuron. It would indicate dystonia. So that's what I meant to tell. So if it is a dystonia with this kind of a weakness, we should think about a completely different set of differential diagnosis. Now we know that this child is having some sort of a contracture, is having some gait abnormality, and with a description where the child is requiring some assistance to get up from the posture and to get up from the sitting posture and to lift his hand up, that means there is some of proximal involvement is there. Fine motor, though grossly it is not involved, but still he is fiddling with buttoning and unbuttoning the shirt. Right, there are some concerns with this buttoning and unbuttoning the shirt. So there could be some weakness in the fine motor, though grossly it looks okay because he's able to copy the diamond and he's going to school, his writing skills are okay. So there is some involvement of the distal also, but the proximal is more evident when compared to the distal, and the lower limb involvement is more when compared to the upper limb because he's able to comb his hair, he's able to take off the shirt with some support. Right? Yeah. So with this history in the background, what are all the differentials that you would be considering here?
From the history, since even though there is a newborn seizure, there is no other history suggestive of cortical involvement, no seizures beyond newborn period, no history suggestive of increased tone, and his history of weakness and floppiness, feeding difficulty, and weakness more involving proximal and isolated gross motor delay. I would like to differentiate it into a lower motor neuron involvement. And in lower motor neuron, it can be anterior horn cell disease or involving nerve or neuromuscular junction or muscle. But from history, anterior horn cell, there is no history of fasciculation, and child is 6-year-old with no mild, comparatively mild weakness. I would not considered anterior console. And for neuromuscular junction also, there is no diurnal variation or worsening on exercise. So, I would like to eliminate a neuromuscular junction also. There is a possibility of nerve involvement or a muscle, of which muscle will be, I would prefer muscle since proximal muscle is more involved. And there is no history of sensory involvement from history. So it might be a muscle pathology.
So you're mainly narrow it down either to the muscle or the nerve. But at this point, I would still keep the neuromuscular junction also as well till we finish the examination and then we come about it. Why we are ruling it out is, one is if it was anterior horn cell, we would be thinking something like an SMA kind of a disease or a SMA-RD kind of a disease. So in these conditions, the child would have worsened without any treatment. Here, the definite history is there is no recurrent respiratory tract infections. He's taking very good amount of food. The amount of food intake itself shows that his chewing difficulties are not there, swallowing difficulties are not there, which can also rule out an anterior horn cell involvement. The nerve is still a possible because some varieties of Charcot-Marie tooth disease can present like that. And muscle is also possible. It can be either a congenital myopathy or it can be a congenital muscular dystrophy as well. There is a history of a maternal uncle with intellectual disability, which can also indicate, and there is another death of a sibling where they had to do a MTP for some cardiac anomaly. So the muscle myopathy or muscular dystrophy is still a possibility over there. It can still be some metabolic conditions because mother is also feeling that the child is very thin, has got a very thin limbs, and that at neonatal period he was quite symptomatic, but then going on okay without much of a problem. So some metabolic conditions should also be considered over here. So those are all the differentials we would keep in mind before we go for the examination as well.
I'm going on.
In the history, as Smilu pointed out, definitely the neonatal seizure which happened on the third day and for which 6 months of anticonvulsants, antiepileptics was put on from our institution needs a little more of details which we need to know. Nobody will be putting the patient on any anticonvulsants for 6 months unless it is indicated. Was an EEG or another investigation done which showed what is the justification? There should be a justification. Otherwise, we need to consider that also. There should be a reason for that. Okay. Most probably, as you said, there must be missing of the hypoglycemia or some other thing. It must be symptomatic seizure. And for which, whether this 6 months anticonvulsants were justified or not is one point. So when you see another thing, in the newborn period onwards, there was the problem we discussed, and there was a feeding difficulty. So there is at that point, in a child with a floppy situation, feeding difficulty, you'll be thinking wide in the cranial nerve territory. So what was the appearance of the face, eyes, and during cry? That is important because there can be a bilateral involvement in a situation of generalized problems of anything. So we need to consider bilateral, facial, ocular, and the swallowing. Everything is important because there can be a cranial part involvement due to motor unit disorders also. So you need to mention about the sound intensity and the facies and expression, whether there's a change in the facies or it is mask-like, because there are a few conditions there. And the feeding, you said there was a feeding problem. Okay. There are some of these entities where the feeding problems are very prominent in the newborn period in a floppy situation. That is diagnostic of few of the conditions. So at that point, we should have considered. And what happened over time? Over time, from that feeding, it is improved, I think. It started feeding part, and that is how you're taking away the cranial nerve territory of the problems. Because whenever you are dealing with a minor junction or muscle disorders, the extraocular, ocular, facial, pharyngeal part needs more of importance. And in that, at that time, you need to mention about the mother's the facies and shaking hands with the mother. Maybe even now during the general examination, you should be looking for the myotonia of the mother, and you should all be asking for a group photo in the family history. Because in the family history, we usually construct a pedigree chart, you ask for the related entities, but sometimes none of them must be dying, but there can be some subtle features which are obvious from the group photo. Myotonic dystrophy is one entity which is to be considered because they can survive. So this is an entity starting from newborn and surviving up to this 6 years. That is, you need to consider all those things. And at the end of the summary, you consider definitely possibility of a motor unit disorder, out of which your analysis of the anterior horn cell is very unlikely because many of them will be progressing. So in this case, it remained a static or a little bit of improvement only, no worsening over time, surviving at 6 years. So you narrow down the possibility to mineural junction and muscle. As Dr. Smilu pointed out, there can be a possibility of mineural junction disorders also presenting like this. There are certain myasthenic syndromes, and also it's not the classical myasthenia only. And you ruled out the peripheral nerve. It's not. There are entities of peripheral nerve starting from very early period persisting like that. It's not an HMSN or something which will be starting late and progressively declining. There are some neuropathies, neuraxis, peripheral nerve involvement, some hypomyelinating neuropathy you have heard of. And one very important entity you need to mention about the pain sensation. It's not enough to say that sensations are intact. There are situations where pain only is absent and the location of the lesion is in the peripheral nerve. So you need to ask whether child cried during ear pricking, needle injury, needle stuck during the immunization, or they didn't cry at all. So those things are also specifically important. There are entities of nerves also which can behave like a non-progressing hypomyelin is a static type of a. So both in the motor unit and in the central, there are static and progressive disorders. So don't think CNS disorder only will be classified into static and progressive. Motor unit disorders are also the static and progressive. So in this case, it's not progressively declining, and it must be somewhere in the motor unit, out of which the anterior horn cell is least likely. Okay, go ahead.
On general examination, child looks wasted with an elongated face and keeping mouth open. Vitals, pulse rate is 90 per minute, regular in rhythm, normal in volume and character. All peripheral pulses were felt bilaterally equal. No radial or radiofemoral delay. Respiratory rate was 20 per minute. Blood pressure was 98/62 mm HT in right upper arm in supine position. Child was afebrile during examination. SpO2 was 96% in room air, and CFT was less than 2 seconds. There was pallor on examination, no icterus, cyanosis, clubbing, generalized significant lymphadenopathy or edema. On head-to-foot examination.
This is the time when you should be including in the general examination other members of the family, whoever is there. It may be the mother, it may be the father, it can be basically mother, other members also, because many of these disorders can be running in the family in varying severity. So there can be subtle clues, especially this is the myotonic dystrophy situation and other myopathies also. So facies of the accompanying persons are important. And you said that there is a mental retardation in the maternal side. So don't ignore. You need to consider that also. Okay.
And one more point is the type of breathing. Because what we see is whether it is abdominothoracic, thoraco-abdominal, whether the intercostal muscle weakness is there or a diaphragmatic weakness is there. So that can also be like added upon in your when you mention about the respiratory rate 20 per minute regular, you can just put the type of breathing as well. So we know that in SMA conditions, what we see is the intercostal muscles are weak. So you see mainly the child is breathing with abdomen on and off. Whereas in SMA RD, that is SMA with respiratory distress syndrome, you get more of the diaphragmatic weakness. So you already get a diaphragmatic weakness and the child is moving only the chest and nil abdominal movement. And in myopathies, you may have a uniform involvement of both the intercostal muscles and the diaphragm per se. So with that also, we may get a clue. And any child who is having this abduction muscle weakness, definitely the diaphragmatic muscles are also involved. So that would also give a clue in the general physical examination itself.
In the facies, you said only elongated facies, nothing else about the facies you mentioned. Okay. The facies, it looks a open mouth. So that also is important. So when you describe the facies, the ptosis and the ocular movement, whether it's moving in all directions, you'll be telling about the extraocular movement. But at this stage itself, what about the movement of the neck and the eyes together? So there's a disparity. Is there any bilateral or unilateral ptosis? And the open mouth appearance in this case is important. So when we are asking about the history, the chewing, swallowing, coordination, all important. Whether this child can eat groundnuts, kadala, chavacharakunna, difficulty in that chewing, especially chewing what happens over time. Myasthenia and muscle disorders, child don't offer groundnuts, as a present day. It will be very difficult. He will want it, but he won't be able to chew. So open mouth indicate there must be some problem with the chewing also. Okay.
Head to foot examination. Size of head appears normal. Dolichocephaly. Hair color texture is normal. No alopecia. There is an elongated face, expressionless with open mouth. And on eye examination, ptosis is present, which is not variable. No corneal clouding, cataract, nystagmus or squint. Oral cavity, he has a high arched palate. There are dental caries and malaligned teeth. His ears are low set ears. There is no thyroid swelling. Chest, there is intercostal precisions. No abdominal distension or hernia. Examination of extremities, there is limb length discrepancy. Right lower limb is longer than left. There is 3 centimeters.
Slow because you are moving fast. Follow
Okay.
Slow.
There is limb length discrepancy. Right lower limb is longer than left lower limb. There is a disparity of 3 centimeters. And there is
limb abnormal. Right limb longer than parandano, ado shorter ano. Which is abnormal, you think?
Contractures are present in right side.
That is the reason why it's longer. Absolute length with just
3 centimeter difference.
Interfere. When you're telling that right limb looks longer, the other limb is normal. Okay. So, longer is it due to a real length discrepancy or is it due to an abnormal attitude? Keeping like that due to contraction and straight and it looks longer than mean chain. That's clarity. Okay. Okay, go ahead.
There was flexion contracture at right hip joint, right knee, and at right angle, which is dynamic. There is a callus over right toe, no tophic ulcers. There is generalized wasting, no hypertrophy of calf muscles. There is no involuntary movements noted. Spine, there is exaggerated lumbar lordosis and scoliosis is present, no kyphosis. Scoliosis is corrected on bending forward, that is Adam forward bend test. An external genitalia, bilateral testis was palpated in scrotum, no inguinal hernia. skin, there is no rash. There was no signs of dehydration for this. And on anthropometry examination, weight of the child is 40.
In the general examination, always look for the muscle evaluation and the bulk. Okay. So a generalized wasting you are commenting when usually there must be generalized disorders responsible for the malnutritional aspect. Okay. When you're getting wasting assessment for a muscle or minor junction, very important is the pattern of that. Is it a generalized wasting or you see a particular pattern which may be fitting for especially it is relevant for a dystrophy situation, may not be relevant, Smilu will agree, for a condition like congenital starting from birth. Still, a neurological part of description of the wasting, the distribution of the wasting is more important. So, in the beginning itself, undress the patient fully. Any patient you are evaluating the muscle, basic dictum is undress even the undergarments because the proximal muscle involvement will not be visible if you see the patient dressed including the undergarments. And look from all sides and look at the intercostal and small muscles. So otherwise a wasting pattern description you'll miss. Okay. So all the muscles including the neck, sternomastoid. So that pattern is important. Proximal muscle deltoid. So what is there a typical pattern for that wasting? So importance in the general examination for the distribution of the wasting is important. Okay. When you are telling about why we were asking about the discrepancy of the limb size, that can only be to a secondary sequelae rather than a pointer towards the dysmorphism. That's why. Okay. A dysmorphism of a limb involvement in this case will unlikely to be occurring on one limb only. So it must be secondary to the muscular problem. So attributable in this case to contraction. Okay. Okay, go forward.
And
Smilu,
most important.
any point, Smilu? I mentioned any mistake or anything? You can.
No, sir, nothing, sir. I just add on 2 points to think. So one is everybody, we like from our point of view, whether we were dealing with the nerve or the muscle is always a confusion from the beginning. So I'd be more interested in the wasting of the thenar, hypothenar muscles and in between the other pad and the dab muscles, whether they are actually wasted or not. And the second, I would be more concerned about the extensor digitorum brevis. So if the extensor digitorum brevis is wasted, then we are dealing definitely with more of a nerve pathology or even a neuronopathy. They can have the initial wasting would start at the extensor digitorum brevis. So these are the 2 group of muscles that we could highlight also and put apart from the points suggested by Pushottam sir as well. Yeah, go ahead.
Thenar and hypothenar muscles were not that much wasted compared to other muscle groups. And on anthropometry examination, his weight is 40, which is between -2 standard deviation and -3 standard deviation. Height is normal. Head circumference is 50.2 and BMI is 11.2. Thinness. Developmental assessment, he walks
About
along.
the head, in a case of a muscle disorder with the wasting and all, it may look like a dolichocephaly situation. So there are situations where there will be wasting of the masseters and the temporalis. Okay. So especially in the newborn baby on chronic dystrophy and all, the head shape may be altered. Okay. So there are bony changes secondary to the peripheral motor disorder. One of them is the head shape, another one is the palate. Okay. Okay, go ahead.
Developmental assessment. He walks alone, runs with an abnormal gait. He climbs upstairs and downstairs with 2 feet per steps, holding rails. He's not able to jump, hop, or skip. His developmental age for gross motor is 18 months. He copies diamond, but he holds pen between index and thumb finger and thumb in an erected posture. He can draw a person test correspond to 8 years. His general understanding is normal for age. He knows number of fingers, names, weekdays, and knows right from left. He does simple arithmetic problem, and his speech is normal. Systemic examination. Initially, I started with gastrointestinal system since the child presented with acute diarrheal disease.
Is there any video showing the gait? Any patient like this? It's very helpful because video are important, especially the go-away sign. You have got it. Okay. Important.
This was a video 6 months back.
Okay. It's very important. Video analysis is very important in all the gait problems, whether it be in the bony situations or in the spastic situations and specific weakness situations. What happens in the gait analysis, visual gait analysis and other gait analysis and Gover sign estimate analysis. All these things are important. Maybe Smilu can contribute more. Okay.
Gastrointestinal system was normal. There is no hepatosplenomegaly. Nervous system examination, higher mental function, child is conscious, oriented in time, place, and person. His attention, concentration, and memory is corresponding to his age. Speech, there is no dysarthria. His comprehension fluency is normal. Voice is normal. Reading and writing is normal. He is left-handed. Cranial nerve examination, normal sense of smell.
Intelligent development assessment, especially you need to look for the intelligence assessment. Okay, cognition, intelligence. Is it important because most probably we are dealing with a motor unit disorder? Should we give importance to the intelligence assessment? Is there any subtle problems in the cognitive domain?
Yes, sir. Some of the muscular diseases are associated with intellectual disabilities and behavior abnormalities.
That is important in this case.
Okay. The most common being, what is one of the most common condition which can have all these intellectual disorders with hyperactivity? DMD. We see a lot of DMD children with behavioral issues and in low IQ as well. And initially they can present as an autism. So many a times we think the child has got only autism, but when we do a screening CPK, you get a very high CPK levels. And the autism child also does not hop and jump for some time. So that maybe we also consider that, okay, because of the behavioral issues, he is not hopping and jumping.
When you're analyzing the speech and voice again, so we need to test two things. One thing is what is happening over time. Make him read a paragraph aloud. So is the amplitude of the voice going down? The other thing, if there is no ptosis obvious at the time when you are looking for, look for the upward, the gaze. Is it fatigability? You can test on the bedside. Okay. 2-3 tests in a subtle case of a minor junction disorders is looking up and look for the fatigability and eyes application. And those are things are can be done at the bedside. It may not be relevant for this case, but when you're dealing with this sort of a case in an older child, all these things are important. The cranial nerve territory. Okay.
Olfactory nerve, he has normal sense of smell. Second nerve, visual acuity, near vision, field of vision is normal. He can identify colors and fundus examination is normal. 3, 4, 6 cranial nerves, ptosis is present, it is not variable. Pupils are equal in size and reactive. Normal extraocular movements, no squint or nystagmus.
Ptosis again, when you mention it is a unilateral or bilateral, whether it is complete or partial, and they change over time from morning to evening, and see the photograph. Oh, very, very important, ptosis. Okay.
Trigeminal nerve, child keeps mouth open. There is no deviation of jaw. There is wasting and weakness of bilateral, masseter, and
Do
temporalis
you
muscle.
expect a deviation of jaw?
No, since
So,
symmetrical.
when you talk about the cranial nerves in a nervous system examination, always you will be telling there is no deviation of the face, there is no deviation of jaw. In a situation like this, there need not be deviation of jaw. So there can be bilateral weakness of all the muscles. It's not the deviation. The other evidences of the weakness.
Yes, sir. Sensation over face is normal. Jaw jerk is normal. Corneal reflex was not tested. Facial nerve, forehead wrinkling, eye closure is normal. Nasolabial folds are symmetric. No deviation of angle of mouth. Power of vaccinator was normal. Auditory nerve, hearing is normal. 9th and 10th nerve, uvula was central. Movement of uvula and arch of palate was normal. Gag reflex normal. 11th nerve, he can turn head to both sides. There is a flexion weakness present. Shrugging of shoulders and extension of neck was normal. 12th nerve, there is atrophy of tongue. There is no deviation of tongue or there is no fasciculations.
Very, very important. I think your point of the tongue atrophy need to be revised because I don't know, is there any muscle or binaural junction disorder which we are going to postulate to produce tongue atrophy? I doubt whether that finding is right.
Motor system examination. His gait, he has a wide-based gait with exaggerated lordosis and with abdominal distension. He's having a waddling gait.
More of that rightly pointed in the chat box again, that scoliosis appears to be more of a compensatory because of that exaggerated lumbar lordosis and the pelvic muscle weakness. To stabilize the gait, the child might be moving to one side, and that could be the reason why that scoliosis has occurred, and which is a correctable one because you're doing an Adam forward bend test and it is being corrected by itself. And to come with a different type of gait, so what are the type of gait that you see in a child with a muscle involvement? Like, for example, in case of myopathies or muscular dystrophies, what is the type of the gait?
Waddling gait.
So in basically what I'm trying to, yes, waddling gait. So you have more of that hip extensor muscles which are weak. So to balance the pelvis per se, they are moving like this. So that is more of a waddle phenomenon, waddling sort of a gait that occurs. So what happens if there is a neuropathy? So what kind of a gait will you get with neuropathy?
Dragging type of gait.
More of a foot drop type of a gait, the tap feeling, as though ipa namukku calendar muscles la theera oru strength illenga, tap 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 tap, that the way they walk is like that, like this, as though it's being very floppy and you're not able to feel the surface of the floor and they're just dropping it just like that. That is a kind of a gait you get when you have a neuropathy. So that is the main difference between the neuropathy and the myopathy sort of a gait. Then you all know about the circumduction, how they actually do a circumduction form like this and they move about. Then in DMD children, they may not initially present with a waddle, they may just present with a tiptoe walking because of that calf muscle hypertrophy and the plantar muscles which are weak and they are getting tightened. You just have a tiptoe walking as such. So those are the basic types of gait that you should see. When the patient just walks into the room, you should analyze the way they are walking. That itself will give you a clue as to which system you're dealing with. That is one thing. And always look for the stance. Stance is nothing but you make them stand still and see how they are standing. If they're standing with little bit of ataxia and a cerebellar involvement, and if they're standing just wide based without any ataxic movements, it could still be a possibility of a muscle involvement. It's a proximal muscle involvement. Yeah, go ahead.
Examination of bulk, bilateral, upper limb and lower limb wasted. There is no asymmetry, no fasciculation. tone. There is generalized hypotonia. Muscles are soft and flabby on palpation. There is no asymmetry. And on examination of power, grip was good. And power of upper limb and proximal and distal muscles of upper limb and lower limb was actually 4/5. But Gover sign was positive, and child was climbing stairs supporting rails 2 feet per step, and he was not able to jump, suggestive of proximal muscle weakness. Lower limb. An examination of reflexes, superficial reflexes were normal. Deep tendon reflexes was diminished, and knee jerk, biceps, triceps, and supinator was grade 1, and ankle jerk was absent. Sensory system examination was normal. Cerebellar signs, there was no nystagmus, dysarthria, head nodding, no finger nose test, dysdiadochokinesia, rebound phenomena is normal. There was no indentation tremor, no truncal ataxia, gait, waddling gait, heel to knee test, tandem walk was normal. Hypotonia was present, no pendular knee jerk. There was no signs of meningeal irritation. There was no peripheral nerve thickening. Skull, dolichocephalic, spine scoliosis was present. There was no autonomic signs. And PGALS was done for the child. Gait, the child was not actually able to walk on heels or toes. Arms, he was able to put hands out, make fist. Opposition of thumb to other fingers was normal. He was able to put hand together and hands back to back, and was able to raise hand looking up at the ceiling, and was able to put hands behind his neck. Legs, there was no knee effusion. He was able to bend and straighten knee. Internal rotation, there was restriction of internal rotation of right hip. Spine, in cervical spine examination, he was able to insert 3 fingers in mouth. Lateral flexion of neck was normal. Seeing the spine from behind, scoliosis was present. And Adam forward bending test was correcting scoliosis. He was able to bend and touch toes. On cardiac vascular system examination, there was no cardiomegaly. S1, S2 was heard normally. No added sounds or murmur. Respiratory system examination, chest expansion was normal. Respiratory was normal. Thoraco-abdominal. Mother, there is history of T1 abortion and a recent MTP. There was no myotonia on examination. There was no myotonic facies for mother. Summary. This is a 6-year-old boy presented to us with acute diarrheal disease with no features of dehydration. Was having a isolated gross motor delay with myopathic facies, and he's having a more of proximal weakness than distal, and lower limb is more affected than upper limb. There was generalized wasting, hypotonia, and diminished absent reflex on examination. There was contracture and scoliosis, and there is limb length discrepancy. There was no fasciculations or myotonia.
So to come to the differential diagnosis, so what are all the conditions which can present with myopathic phases right from the birth?
Myotonic dystrophies and congenital myopathies.
And congenital myasthenic syndromes. All the 3 can present with a myopathic sort of phases. So that is one. So any other things that you can consider over here? It could be some chromosomal abnormality also. No? Will you consider or will you not consider? Like A Down syndrome child can also have hypotonia. What is the difference between that hypotonia and this hypotonia?
That is central hypotonia.
Yeah, that's exactly what we want. That is actually a central hypotonia. So just because when you see a hypotonia child, this is in general for all PGs, do not jump into that the hypotonia is always a peripheral hypotonia. So one thing over here is it's not just the hypotonia, it is the weakness. A hypotonia child may not have weakness. That goes more in favor of a central cause. Whereas a peripheral hypotonia is always associated with weakness. That is one thing. And second thing is all these contractures, scoliosis, they are usually present when there is proper muscle weakness which is there. So that itself will indicate you're dealing with more of a muscle rather than a central hypotonia. That's a difference between a central and peripheral hypotonia, basically. Okay, so with this different, then what are the differential diagnosis you considered and how did you go about further?
So, considering a nervous system involvement, can to differentiate first whether it is an upper motor neuron involvement or a lower motor neuron involvement. Even though child had a neonatal seizures, we can at this point can attribute an acute symptomatic seizure and no other features of involvement of cortical involvement. And on examination also, child is not having there is no hyperreflexia or hypertonia, and his cognition is normal. It's having isolated postmotor delay. At this point, the can narrow down to lower motor neuron involvement. And in lower motor, we can consider it can be a anterior horn cell involvement, nerve involvement, or neuromuscular junction or muscle involvement. So for anterior horn cell, as already discussed, this is a 6-year-old child and likely to be in this level of health if he's having anterior horn cell disease. And there is no fasciculations. And considering nerve, neuromuscular junction and muscle, neuromuscular junction can be out since even though the ptosis is not variable, there is no diurnal variation, no fatigability, and he's not receiving any treatment. He could have worsened at this point. And then we have muscle and nerve, of which nerve will be having more of a distal weakness and sensations will be also affected, though nerve can also be considered as in some some neuropathies like Charcot-Marie-Tooth can have proximal muscle weakness also, and the sensory involvement can be mild. And I'm mainly considering muscle as my differential since he's having a myopathic facial weakness, hypotonia, and with diminished reflex and involvement of proximal muscle than distal. And
So why not muscular dystrophy? Why myopathy?
Muscular dystrophy will be a progressive disease. From his history, it's kind of either static or slightly improving over the period. And also in dystrophy, there will be hypertrophy and atrophy. So in this child, there is no hypertrophy.
So basically, in case of congenital muscular dystrophy, majority of them will be associated with the cognitive issues as well. It need not be just an isolated motor delay. They can have some cognitive issues. That is one point. And usually the main difference between myopathy and muscular dystrophy is like a myopathy child is like a low powered horse. So the horse is having a low power, but it will finally reach its destination. So even though there is a floppiness observed at birth, over a period of time, they will usually catch up. That is with myopathy. Whereas a muscular dystrophy, they tend to worsen over time. Just rightly you said it is a progressive condition, so it can worsen over time. So here the myopathy would be more when compared to muscular dystrophy. Myotonia is still a possibility over here, like myotonic dystrophy. But for the myotonic dystrophy also, they usually improve with time, even without a treatment. But the most important part is the mother did not have myotonia, other family members did not have myotonia, child did not have myotonia. That is why you have not put that as your one of the differentials. And Charcot-Marie tooth can also present with all this scoliosis, contractures at birth, but the main thing is the distal involvement will be more than the proximal, which is a common presentation of Charcot-Marie tooth disease. Okay, yeah. So how will you go about further? You can go with the investigations and then we can come to this.
Samiha, a few points in your CNS examination so far, we were telling lower limbs are more weak. There is a proximal distribution. But when you presented the power, every group was 4/5. Definitely the examiner will catch you because you are contradicting. During the clinical history and all throughout, there was a difference in the power. But 4/5 in all the group, that's unlikely. In this case, most likely, you should be comparing what is the normal for that age group. That is why you have underestimated the distal power. Definitely, proximal weakness is more likely, distal comparatively. And whenever you assess a child, the parent's concern is what can I do for you, for him, and whether this will progress over time. So most likely it is a myopathy. It is unlikely to progress further. And this is an entity which is not affecting the heart or brain or other systems, only muscles. Basically, longevity is assured, it won't be progressing. But there are problems and limitations for him with the day-to-day activities, day-to-day life problems. And there is a chance of worsening due to the deformity worsening. So those things you need to consider in the evaluation. So what are they? What about the manipulation in the daily life with a boy or child needs? So you mentioned about the holding of the cup, the other things also which are needed in the day-to-day life, whether he can open the tape in the bathroom, whether he can open the bottle, this thing. So whatever little things which is needed, is it spared or not? Maybe distal power is normal and it won't be worsening over time. So what all things you can do is one thing important. The rest of the other important thing, Mohandas was asking and another person was asking about the reason for the disparity. Is there a contraction already? What is the reason for that? So that was not answered. The another one is the deformity of the spine. There is a chance that over time, if you are not taking care, even when the weakness is static, there can be a worsening due to the growth and the posterior part. So during the growth, you need to take care of the spine bending, which are very likely to worsen over time. So that is very important in the further management. Then one very important thing in the other system. You mentioned about the cardiac involvement is so important. Two things, tongue large and heart large. So in this case, you told about the wasting of the tongue. It's unlikely, but metabolic problems affecting the heart, muscle, and the tongue. So that's a diagnostic clue in the general examination part. In this case, both are not involved, but the lung functions are very important. In a case, there can be restrictive lung disorder with the chest deformity. So at 6 years, we should have a baseline pulmonary function test. Is there a evidence of a restrictive lung disease? And that is the one thing which you need to be followed up. So there can be questions about the other systems also rather than going forward, R&D equal this thing. But what way this disorder can have an influence on the systems is what they'll be asking. Okay. Go ahead with the investigation.
For investigation, hemoglobin was 10.8, hematocrit 34, MCV, MCHC, MCV was low, MCH is 22 slow, MCHC 30. Total count was 9,600, was lymphocytic. Platelets 3.2 lakhs was normal. RFT is normal. Electrolytes, potassium is 3.2. And SGOT, PT, OT was
When
35.
we talk
and
about the investigation,
Potassium.
few things which are not relevant can be skipped. Actually, it's very unlikely to cause any change in the TC, DC, hemoglobin and all. So what is relevant hematologically is to be highlighted first. Okay, what are you interested? The CPK, LDH, SGOT, like that. Those are the things which we are interested. So relevant investigation should be highlighted. Okay.
SGOT, SGPT was normal. CPK was normal. It was 21. Thyroid function test was normal. Nerve conduction study actually is pending. He was not cooperative for examination. And genetic testing is also pending for this.
Is there any more relevance for the EMG in this case?
Yes, sir.
Smilu was pointing out
Myotonia.
myotonia, if it is a possibility that will be occurring almost by this time, by 6 years or so. It may not be there in the earlier age group, and EMG as well a typical finding. Okay, NCV is definitely important. EMG also is important, a bit difficult to do in a child like this, but that is a diagnostic finding in the EMG in a myotonia. What is that finding?
Dye-bomber noise.
Okay.
While inserting the needle and while contracting the muscle.
So the next question would be like what sir was actually pointing out. How do you manage this child? We will do genetic testing and all that all will be taken care of. But like what will be the pattern? Like how should we counsel the family and how should we go about with the further management? What are the aspects that should be looked for?
First of all, supportive management should be done. Before that, other cardiac evaluation, respiratory evaluation, pulmonary function tests should be done. And supportive management in the form of physiotherapy, muscle range of motion exercises and strengthening exercises. And orthopedic consultation should be done for contractures, and genetic testing should be done, and for particular mutations, treatments can be tried, and like L-thyroxine and pyridoxine can be considered in ACTA1 mutation.
Okay, so the most important thing over here is sometimes only our pulmonary function test may not suffice it. So we may have to consider sleep study in many of these children, because what they might be having is a central hypoventilation. One of the reason why the child might not be gaining weight could also be because he might be having a hypoventilation at night going on. So it's always important for us with that kind of a muscle wasting and that sort of an open mouth that we have to do a sleep study, mainly to rule out if there is any apneas, hypopneas that are happening at night, so that look for an early morning ABG, look for a PCO2 levels. If there is a high PCO2 levels in the early morning ABG, that really indicates that the child may need a BiPAP. And over here, a CPAP support may not actually help the child, because the child, what he needs is a bilevel positive pressure ventilation rather than just a pressure support as well. So that also needs to be considered as a part for the pulmonary function testing, because many of us, we either fail to do and we may not do it because of financial reasons, but but this is one of the important thing. And a child with such open mouth, though having myopathic faces, if you see the general anatomy of the face, he might also be having a large adenoid as well. So it is always better to do a scopy by a ENT specialist to look for any adenoid hypertrophy, because these are all the common causes for an hypopneas that might be happening throughout the night. So that also needs to be considered in the management of these children. And if many a times what we see is a heart per se in the echo will appear normal, but if you do a long lead ECG or probably a Holter monitoring, we may pick up subtle cardiac rhythmic abnormalities which may get missed at this point of time. So that always look for a long lead ECG and look for a cardiac rhythm irregularities as well, because sometimes this child who is like happily going, he may suddenly collapse. And only when he collapses, for example, one of the things that we see is early contractures at birth, and the child developing slowly without much of a myopathic phases are this Ulrich kind of a myopathy, and a Bethlem and an intermediate varieties of collagenopathies can also present in a very similar fashion. And these children, they'll be walking, talking normally, and suddenly they will collapse. And the moment we put them on BiPAP ventilation, they will improve as well, and they will just move around also pretty well. So that is the reason why we should look even for the rhythm irregularities also in these children, apart from the structural abnormality of the heart. Then another important aspect is this child has not taken any optional vaccines like pneumococcal vaccines, yearly flu vaccines. He's just lucky that he did not have recurrent respiratory infections, because looking at his respiratory reserve with that kind of a muscle, if he gets a pneumonia, it will be very difficult to get him out of a ventilator. So to prevent it would be the vaccination aspect of which that needs to be considered. So system wise, if you take for, first thing would be to look for the cardiac system, respiratory system, immunize the child properly, a proper nutritional rehabilitation, because even though he is taking that much calorie of food and a good amount of protein, his weight is still on the low. I understand that with myopathy, we may not be expecting a good amount of weight, but his hemoglobin is also low, which indicates that there is some nutritional deprivation that is happening at the same time. Looking for the bone health of the child is very important, and that's the reason why you have done a calcium alkaline phosphatase and a bit of vitamin D and everything. So that also needs to be considered. Providing the child with vitamin D and calcium supplements should also be a part of the management as well. Then comes the genetic part of it, like what is a common mutation and how to go about. So do you think what would be a feasible option, whether to go for a biopsy or whether to go for a genetic testing? What would you do at this point of time?
Genetics testing.
So genetics mainly because it is more confirmatory, least invasive, because many a time you do a muscle biopsy and then you get a report like a probable core myopathy. A core myopathy can be caused by a lot of mutations, can cause a core myopathy. Lot of mutations can cause a centronuclear myopathy. So again, we are confused as to what is the exact reason for his myopathy, and to provide genetic counseling, because already they have lost one child, they have to undergo MTP. So they must be planning to expand their families as well. So that would be the reason why you would consider a genetic testing for this child. So what are all the common mutations which causes myopathy? Just a few common ones. A lot of mutations which can cause congenital myopathy. What are all the common mutations that you're aware of?
RYR mutation, ACTA1 mutation, NEB mutations.
So basically nebulin, actin, and ryanodin. So ryanodin RYR1 will cause more of dystrophy, but RYR1 can also be associated with myopathy as well. Other ones are actin and nebulinopathies, which we see commonly. So can you name some myasthenic syndromes, congenital myasthenic syndrome, any common mutation which causes a myasthenic syndrome? No, why I'm talking about the mutation at this point of level is because this very similar picture can be seen with CHRNE mutation. And a CHRNE mutation is one of the commonest type of mutation which can present with a congenital myasthenia, where the child will have ptosis and the child will have ophthalmoparesis, which are also fixed. And usually when we give pyridostigmine, there will be a very subtle improvement, but not complete improvement of the ptosis as well. So sometimes that can be very confusing to the myopathy also. So that was the reason I just brought that also, because whenever we talk about myasthenia, all of us are aware that myasthenia is always a fluctuating, a diurnal variation, that kind of a weakness. But congenital myasthenic syndromes like CHR and any type of mutations will have a fixed ptosis and a fixed ophthalmoparesis. And a little bit of improvement of ptosis can happen with pyridostigmine. Anything else that you would do for the family, do for the child? A spine brace, yeah, that definitely helps. But a spine brace also can help this child because he's having a lot of this instability by walking, and a brace to just to make everything sit together, that can help. And some sort of orthosis, because definitely screening the hip is very important. Hip dislocations are very, very common. And if hip is dislocated, again, the question comes whether we should do the surgery or not do the surgery. Because since the muscles are weak, and if you do a surgery, again, there is a possibilities of dislocations as well. So again, sitting with the family, knowing the natural course and giving them a correct opinion also matters over there. So spine brace and orthosis, especially for the contractures, some ankle foot orthosis, whether it is needed, that also needs to be considered over here. And do you advise vigorous physiotherapy for this child or a subtle physiotherapy? What would be the kind of physiotherapy that you would be advising for this patient?
Subtle physiotherapy. Since he's considering myopathy, range of motion exercises and strengthening exercises are advised.
Yes, and never to use weights for exercising, because there is a lot of physiotherapy practices which goes on. They say that the muscles are weak, so we add upon to some weight bandages to that lower limb and upper limb and make them walk. They will continue to walk and the muscle will gain strength, but that is not explained. That cannot be done for these children, because the muscle power will eventually be lost by adding on weights for this child. So sir had asked a question is how do you explain why the child is having absent reflexes? So why do you think the child has absent reflex? Any reason?
Can have diminished or absent reflexes.
So for the reflex arc to perform, you need the muscle and the tendon also to be intact, right? So you're having a lot of contractures. The right lower limb contractures are there, and that could be the reason why the reflexes were absent in your case. But still, we have not done nerve conduction yet. So we should also keep in the mind about some neuropathy conditions as well as one of the possibilities over here. But the contractures could explain why the reflexes were absent. And mitochondrial muscle diseases, storage disorders can also present in similar fashion, where they can have this wasting. The myopathy can be a presentation, but then usually the mitochondrial ones, when the child has a fever or any intercurrent illness, they worsen. Like the child did not have any such worsening in between, and I see in your investigations the lactate levels were also normal. Anything else?
Very well discussed about that the treatment plan, because that is very important, which we usually neglect that part. Myopathy, it won't be progressing and you just leave alone. But we should be discussing with many other, one thing is that with the family, but the teachers also in the school environment, this education situation, how we should be managed during these school hours. The competitive sports should not be allowed. So there's a chance of spinal problems and the dislocation, spinal cord injury also is likely. Yoga type of things may worsen the problems. Definitely in the evaluation of the pulse, cardiac evaluation in different muscle disorders are different. In a dystrophy situation, echo is more important. Here in this case, pulse volume and the rhythm is important. ECG carries more value. Rhythm strip is more important. If at all you are doing an echo, it's not needed annually. The ejection fraction sometimes may be relevant, but more important is the subtle problems of an arrhythmia. So rhythm slip, as Smilu rightly pointed out, that is important to manage. And vaccination is a very important point because influenza vaccine, this is a candidate for all the prevention of the respiratory relevant vaccines. The influenza vaccines and pneumococcal vaccine most probably are the relevant one. RSV type of vaccines also may be relevant in this age group, because in the pediatric age group below 5 years only we are stressing on the influenza vaccines. 5 to 18 nobody is stressing, but selected groups of patients, they are more susceptible, they may die during an episode of pneumonia, they should be getting influenza vaccines. Very relevant point. Okay. About the genetics part, which one will be using? MLPA? That's the point.
MLPA can be considered narrowing
ML
down.
MLPA will be helpful for us only when we are dealing with muscle dystrophy like DMDs and BMD. But otherwise, we are looking more at point mutations. So for point mutations, we need to look for NGS-based exome sequencing, either clinical exome or a whole exome sequencing, and definitely rule out mitochondrial conditions as well in this scenario.
For the PGs, when you are getting a newborn, you are discussing this situation, 2-3 areas which you are very likely to miss is the evaluation of the palate, evaluation of the hip, and the testis, whether descended or not. Always include the Ortolani Barlow's test in a case like this. Always look at the testis, whether it is descended or not. Always look at the palate, because they are all secondarily causing. It's not part of deformity or deformation sequence. It is due to the weakness which can lead on to this thing. And at this stage also, Smilu was pointing out the integrity of the spine. Very, very important is the hip also. So there is a need for evaluation of it, including the orthopedic. There can be subtle problems in the hip and tendency for this thing, dislocation. Very important. So well discussed, both of you. Dr. Srilitha also. Srilitha, any comments? ഞാൻ കുറച്ച് ഡോമിനേറ്റ് ചെയ്ത് പറഞ്ഞു, സിലതൊക്കെ അവസരം. സിലത ഇല്ലേ, പറയൂ.
ഉണ്ട് sir. Yeah, it is all aspects have been covered.
Sir, ഇവിടെ ഒരു doubt ഉണ്ടായിരുന്നത്, probably what would have happened is neonatal period start the anti-epileptic, the patient would not have come for follow-up. And usually that's what happens. നമ്മൾ feeding difficulty എന്ന് പറയുമ്പോൾ we will continue because we may think the child is still encephalopathic and ask them to continue for another 2 weeks. Then what they do is they just don't turn up for follow-up, and that 6-month immunization, somebody would have told from periphery that why anti-epileptic is still ongoing, go to your primary doctor, and that's how they come and that gets stopped, which could be one of the reason, because many times we have seen that scenario in the practice as well. But a lesson for all the PGs is, when acute symptomatic seizures, when you know it is acute symptomatic, we can very well stop early rather than to continue the anti-epileptics.
This child, I heard that this child had a very continuous seizures, and probably after that also this child was having hypotonia. Maybe because of that they were found a neurologically abnormal child, a baby എന്നുള്ള രീതിയിലായിരിക്കാം ഒരു പക്ഷേ കണ്ടിന്യൂ ചെയ്തെന്ന് ഞങ്ങൾ വിചാരിക്കുന്നത്.
So one question was there regarding some persons will go for surgery for contractures. What is the opinion? So for contracture surgery totally depends upon how much is the muscle weakness. Like I have seen in children with SMA and all, there are a lot of this fixed contractures of the hamstring group of muscles. So because of that, what happens? The child keeps both the lower limb like this, and the lower limb will be like this, fully fixed, contracted, and the child cannot sleep and all. But what I have seen is they have done surgeries for these contractures, but again that limb goes like that only. The main reason is the weakness is more severe, that the contractures cannot be completely corrected as well. But then we have to explain to the family. Some families may feel that relieving the contractures may temporarily give some benefit for these children, and they may still be willing for going for the surgery as well. But always look for the degree of muscle weakness, explain to the family, keep the orthopedician in loop and then go for the contracture surgery. And orthopedician alone should not take a judgment for the contracture surgery as well, because many times I've seen that also. Like they say that once we do surgery, everything will become okay, and they just go for surgery, and parents are disappointed that it does not become okay. It is back to the square one. And it's neuromuscular is always a team. A single pediatrician, a single pediatric neurologist cannot handle it. So you need a good team of people who are a good dietitians, good ENT doctors in your team, and a physiotherapist, occupational therapist, sleep medicine, pulmonology. So and cardiologist especially. And so all of them put together should handle the child with care rather than a single person handling the neuromuscular case.
So multidisciplinary team.
Yes, ma'am. Correct. Multidisciplinary team management.
Regarding contractures, sometimes the contractures may be functionally that can be useful for the patient also.
True. And we have seen that the walk, like rightly ma'am said, sometimes with the help of contractor, child might be walking. And the moment we release it, the child gets into the wheelchair as well. Any other questions from anybody?
If there are no more comments, we'll wind up. That's a boy. Thomaso, Nisha. Nisha.
Yes, sir.
That's a കാണുന്നില്ല നമുക്ക് wind up ചെയ്യാലോ.
Yes, sir. So, on behalf of IAP Kerala and IAP Kottayam, I would like to thank faculty, Dr. Smilu Mohanalal, the mentor, Srilata Madam, and the presenter, Dr. Samiha, for this extensive and elaborate discussion. I also thank Purushothaman sir for adding those valuable points on the examination history and all. And also, I thank each of the postgraduates, faculty, seniors who joined us. And thanks to the IAP Kerala office bearers, Dr. Riyaz sir, Kobi Mohan sir, Dr. Renjit, Dr. Binikutan and all, and Mohandas sir and Deshan sir for giving this platform to the IAP Kottayam. Thank you all. Good night.
സമീഹ ഏത് ബാച്ച് സമീഹ ഇവിടെ തൃശ്ശൂര് പറഞ്ഞേ?
You're muted, Samiha. Can unmute.
2015 batches.
ഞാൻ ഓർക്കാത്ത എന്തേ? മറന്നുപോയതായിരിക്കും, വയസ്സായില്ല അതാ.
കുറെ പേര് ഞാൻ ഇങ്ങോട്ട് വന്നിട്ടുണ്ട് സാറേ.
അതല്ലേ? നന്നായി. പഠിക്കട്ടെ കുട്ടികള്. അപ്പൊ ശരി എന്നാ, അപ്പൊ ഗുഡ് നൈറ്റ്.
Thank you, sir. Thank you, Srilata ma'am.
That's a good discussion, excellent discussion, covered majority.
You also complimented the whole thing.
True, sir. Thank you, ma'am. Thank you, Dr. Samiha. It was a good presentation. Thank you.
Right, okay, bye.